Welcome back everybody, Dr. Rossi, shrinksandsneakers.com. So in this video, I'm going to start the next section or the next medication on New Medication Monday, New Mechanisms and Old Tricks. So let's go ahead and crack right into that medication and see what we're talking about here. So the next medication that I selected is called Lumateperone. That's how you pronounce this. And Lumateperone is actually already FDA approved for schizophrenia, and it's also looking to gain approval for bipolar depression. And we can take a look at the mechanism of action to give us a better idea as to why this medication might help with bipolar depression, as well as why this is a medication that can help with schizophrenia. So the mechanism of action, to begin with, let's look at some of the old tricks, right? 5-HT2A receptor antagonist. This is common not only with lumateperone, but amongst most of the atypical dopamine blocking medications or antipsychotic medications. So 5-HT2A receptor antagonist is a common mechanism used by a lot of medications already. So this is nothing really new. And that's a lot of what makes atypical drugs atypical. The next thing that is similar or to other mechanisms and other drugs is, if you notice the third point down, dopamine D2 receptor. So it's a presynaptic partial agonist as well as a postsynaptic antagonist. So at the D2 receptor, so D2 receptor blockade is most of what the antipsychotic or dopamine blocking medications do. So these dopamine blocking medications are going to mostly block D2 receptors. There were some drugs developed over the years, aripiprazole, brexpiprazole, which have partial agonist activity at the D2 receptor. And what that basically does is it balances out or modulates the amount of dopamine blockade and stimulation. So this is why in patients who have depression, things like aripiprazole or brexpiprazole might help their depression, because they might be in a hypodopaminergic state, meaning they're going to need a slight increase or boost in dopamine to improve their mood, whereas people with schizophrenia generally have an excess, and so this will stimulate the receptor enough, but it will actually act as a blocker in that case, because it will be stimulating the receptor and blocking the excess dopamine from stimulating the receptor further. So what you get is kind of a balancing out effect. So there's like, say, instead of 80% blockade of the D2 receptor, you get more like 40% or 50% blockade or something along those lines. I can't recall off the top of my head exactly how much it is with aripiprazole, but that's the general idea behind the partial agonist activity. And then what's a little different here is that this presynaptic terminals versus postsynaptic, so that may be a little bit different than what we see in those other drugs. The newer things is that they've added serotonin reuptake inhibition properties, right? So it also blocks the serotonin transporter, or blocks, or reuptake inhibition is blocked, which leads to increased serotonin, which may help with the depressive component. And this may be partially why, or somewhat explain why it's helpful in things like bipolar depression. Although in general with bipolar depression, we do not like to give antidepressant medications or ones that block the serotonin transporter. So basically, that's also kind of an old mechanism, but it's thrown in here with a medication that's being used primarily to treat symptoms of psychosis, which is the slightly different part. And that might also help potentially with negative symptoms, potentially. The newest part of this mechanism that I want to turn your attention to, though, is this D1 receptor-dependent modulation of AMPA and NMDA receptors. So it's going to act as an agonist or stimulator for these NMDA and AMPA receptors, ultimately modulating glutamate through the D1 receptor. So it's kind of a complicated mechanism, but essentially you're using the agonist activity to modulate glutamate activity. And there is also a glutamate hypothesis for schizophrenia. So some people think that glutamate being the major excitatory neurotransmitter in the brain, this would be something you'd want to modulate or dampen down, and it could be an excitotoxicity kind of situation where there's literally too much glutamate. So this is a new mechanism is very interesting, and it's been of interest in psychiatry for some time now. This is the first medication that I'm pretty aware of that focused on this. I don't know if there's any other ones off the top of my head, but this one comes to mind as one of the first. The side effect profile is also very important for lumateperone. The biggest problem we have with most of our medications, especially the dopamine blocking medications, is not that they don't work. They actually usually work pretty good for especially positive symptoms of psychosis or positive symptoms of schizophrenia, but they come with a lot of side effects. The caveat is always side effects. So what we see with lumateperone is we see less weight gain, which is important. The weight gain generally leads to metabolic dysfunction. This would be problems with glucose, problems with lipid levels, glucose levels, as well as extrapyramidal symptoms and EPS. And the EPS and akathisia. Prolactin is a problem with patients who take Risperdal specifically, or paliperidone, which is the active metabolite of Risperdal, and QTc prolongation. So we see less of that with lumateperone. So already we're saying, okay, this medication is effective for overall symptoms of schizophrenia, but it also comes with the added benefit of not producing the same side effects majority of our current medications have. There were some reports in the studies of sedation, and that can be eliminated by or mitigated by taking the medication at night. So if you take the medication at night, you're generally in a good place because you'll be tired when you're going to sleep, but you won't be tired, hopefully, when you wake up. And the other thing that's nice about this medication is once daily dosing, 42 milligram dose. So it's once daily dosing, which is a huge help as well. And the reason I say that is medication compliance is already a difficult issue. It's difficult for anybody who's taking a medication, not just patients with psychiatric disorders, but any patient. So what they find is if you give once daily dosing, like 80% of people can handle that and will be compliant. If you do twice daily dosing of medication, which things like Risperdal are twice daily, usually 2 milligram per day, let's say, those people are going to have only about a 60% compliance rate, and then it's like 40% if you do TID or 3 times daily dosing. So single daily dose, taken at night, less side effects. And one of the interesting things is that when you switch patients from a standard of care antipsychotic medication to lumateperone, there's actually a decrease in the metabolic risk factors. So that's excellent. That's exactly what we want to see. That's a huge benefit. Lumateperone is also as safe as placebo in the short term and can actually reverse potentially some of these cardiometabolic burden caused by other medications. And specifically the prolactin elevation here is significantly lower risk with lumateperone compared to things like Risperdal or paliperidone. So the last part I just want to discuss is what some of these clinical trials found. So the clinical trials showed that lumateperone 42 milligrams compared with placebo significantly improved schizophrenia symptoms with efficacy like or similar to Risperdal 4 milligram per day. So that's interesting. The medication is not that much more effective than medications that already exist. So what benefit, you might be saying, Dr. Rossi, are we getting from lumateperone then? The benefit was the previous slide and the side effect burden and metabolic burden. So the long-term use of this medication could potentially be much safer than things like Risperdal. And the reason I say potentially is because we need time and patience to use this medication for a while to see whether or not these any of these adverse side effects start to develop later in the course of treatment. But it's similar efficacy to Risperdal, so that's good. It also has a similar safety profile to placebo, and it's favorable. And it's more favorable when compared to Risperdal, so it's better. And again, it doesn't have that risk of prolactin, which Risperdal has. So it seems like in a lot of these trials, they compared it to Risperdal specifically as a standard of care medication. Also, the open label safety studies, patients switched from standard of care, and this was what I talked about in the previous slide, actually had less weight gain, metabolic, and prolactin parameters. So basically, to sum it up, lumateperone is a new medication that's quite expensive. It has a few benefits. One, it's got once daily dosing, so it makes it very easy. A person can take it at night before bed, and then they should be good and covered for the entire 24-hour period. The second part that's really important here is that it lowers the metabolic and cardiometabolic side effect profile and possibly reverses some of the damage caused by other medications of a similar function and efficacy. It also compares favorably to placebo, compares favorably to Risperdal up to 4 milligrams per day, which is a reasonable dose. And It is generally well tolerated by patients without the risk of prolactin elevation seen in medications like risperidone and paliperidone. So basically, an overall better medication for your patients in terms of side effect profile, and it also has a newer mechanism of action that may prove to be in the future more effective, but at least we know it's as effective as the current standard of care. With that said, I'm going to wrap this video. If you guys like these videos about new medications, please like and subscribe to the channel, and we will continue making new ones.